Anatomical and Functional Alignment by Dr. Abhishek Das. Now, I invite Dr. Abhishek Das.
This one is yours.
In the morning, when Dr. Adarsh and myself were in the TKR, we were having a lot of confusion about kinematic, functional, and anatomical alignment. So we'll take it from here, and would be a very interesting topic for everybody.
Good afternoon, dear delegates and respected seniors. At the outset, I would like to thank Dr. Ashish, Dr. Aryan Singh sir, for this excellent organization of the master class, which is very helpful for us as well as younger generation surgeons. I would like to keep this topic as interesting as possible because this is a very didactic topic and a dry subject, at least for me when I was a younger trainee. So, what is the goal of TKR? Goal of TKR is to restore the neutral mechanical axis of the limb so that all the deformity is corrected, and in turn patient have a pain-free knee which functions well. The components are positioned in neutral mechanical axis so that there are even distribution of stresses. This leads to even wear of the mechanical prosthetic joint, which in turn leads to increased longevity. For this, the utmost importance is of preoperative planning, and I would recommend long leg alignment views for whether it is a complex or a simple knee, we should have a long leg alignment view. So let's understand what is these axes that we talk about. What is a mechanical axis? So mechanical axis is nothing but a line drawn from the center of the hip to the center of the ankle. Now, this is not to be confused with the weight-bearing axis, which is actually from the center of the hip to the center of the ankle, whereas mechanical axis, if we take it for the femur, it is from the center of the hip to the center of the joint line or the femoral notch, whatever you take. And the mechanical axis of tibia is from the center of the joint line to the center of the ankle. These two doesn't match when there are a lot of deformities. A severe varus or a valgus, these two axes won't match, and actually the goal of TKR in these cases is to make them similar. What is an anatomic axis? Anatomic axis is a line drawn to the center of the bone. We need to take a defined bony point, which is by convention 10 centimeters proximal to the medial epicondyle and 10 centimeters distal to the tibial tubercle. What is a joint line? Now, joint line is not parallel to the ground. Joint line is actually in 3 degrees varus to the tibial axis. It in turn is about 3 degrees valgus to the femoral mechanical axis, which would make it approximately 9 degrees valgus to the anatomic axis of the femur. Why do we have these two alignment concepts? Traditionally, mechanical alignment concept, which was proposed by Insol, has been the commonest used, simplest to understand, and works very well. However, it has some issues. Hence, we had anatomical alignment axis, and the goal of both of them is to recreate neutral mechanical axis. What is mechanical alignment? It is the cuts are made perpendicular to the mechanical axis. In tibia, both the axes are same, so you just cut perpendicular to the anatomic axis, which will be perpendicular to the mechanical axis. In the femur, you have to make your distal femur cut perpendicular to the mechanical axis, which is in 6 degrees valgus to the anatomic axis. We use anatomic axis because this is what we can reproduce intraoperatively by putting an intermedullary rod. So you take the distal femoral cut in 6 degrees of valgus. Anatomic alignment. So the problem with mechanical alignment is that it forces the joint line in unnatural position. The joint line is in about 3 degrees of varus, whereas if we take the mechanical alignment concept, it becomes parallel to the ground. So the proponents of anatomical axis way back in 1980s proposed that we should have the joint line obliquity maintained. Hence, tibia cut is taken 3 degrees varus and distal femur is cut 3 degrees valgus to the mechanical axis. which in essence is 9 degrees valgus to the anatomic axis. The problem with anatomical alignment is that there's no long-term studies which actually give robust result that this works. This is again a diagrammatic representation of what we have discussed. What is the confusion here? Why do we need all these alignment, 2 or 3 alignment concepts? It is because knee is not a simple joint. If we use the mechanical alignment concept, the joint line becomes neutral. It is not, has its natural obliquity. The knee kinematics is again disturbed. We have got single point of kinematic axis along which the flexion takes place, whereas in the normal knee, there are multiple points of axis where the flexion of the knee on the femur takes place. So the crux here is that the rule of thumb doesn't always work. You have to mix and match. You have to understand the basics of these 2 alignment concepts at least. Say if a patient is very short, that is less than 5 feet, then you have to increase your valgus cut. You have to take the anatomic alignment concept into consideration. If the patient is very tall, more than 6 feet 4 inches, then you have to decrease the valgus cut. Again, this is just what you would normally do if you have a varus knee. The knee is forced laterally. Your alignment goals are to bring this back so that the mechanical axis falls through the center of the knee. And same thing is in the valgus knee. Now, because there is no consensus, people again came up with another theory, which was kinematic alignment axis. I haven't gone through it in my talk because of the time constraints, but the idea is that it accommodates for the various points of axis for the knee flexion, especially in the femur. The problem with the kinematic alignment axis is that it creates very vast outliers. Hence, people came up with restrictive alignment axis concept, where they fixed the range that is within plus and minus 3 degrees of the normal neutral mechanical axis. So, the latest concept in alignment is functional alignment, and one of the key reasons for having this alignment is because we have got new gadgets to play with. These are robots, these are the computers, these are 3D CT scan available, which can give you very nice, and programs which can give you 3D virtual models where you can plan and play in your office and then actually work it out on the patient. So the whole concept here is implant positioning, recreating the native joint plane and obliquity as dictated by the soft tissue envelope. We have to use a pre-op planning CT scan, and you get a 3D virtual model of the knee. This technique is pretty reproducible in experienced hands at least. Use of surgical aids like robotic technology and computer navigation is recommended. So what do we do here? The whole concept is dictated by the soft tissue envelope. The soft tissue laxities, especially in flexion, is taken into consideration. You have 3D virtual gap balancing, and the maximum play allowed is 1 millimeter on the medial and the lateral compartment gap difference. The final gap aim, that is combined thickness of implant with thinnest polyethylene, to be used in both flexion and extension. With regards to tibia, you have a coronal alignment which is matched resection so that it recreates the medial proximal tibial angle modified by the soft tissue laxity. With regards to sizing, you have to ensure that there is no overhang medially and should aim for no overhang laterally as well. And there is maximum one size difference with the femur. Some components do not allow you even that much of play, so you have to be careful about which implants you are using and which robot system you are matching it with. Slope, it is matched with the medial tibial plateau, and the rotation with Akagi's line. This is a new concept where the rotation is taken based on the CT scan with the medial tibial plateau matching with the attachment of the PCL. On femur, again, the coronal alignment is mass resection using the lateral distal femoral angle modified by the soft tissue laxity, and the posterior condylar axis is taken. The maximum internal rotation allowed is less than 3 degrees. There should be no translation in this one as well. Sizing, you have to use a matched anatomy with no overhang or overstuffing, and if there's no trochlear dysplasia, then you restore the trochlear groove. If you have trochlear dysplasia, then it becomes even more challenging. Maximum flexion allowed is up to 10 degrees. So what is the overall aim? The overall aim is to have a final femur and tibia positions dictated by the soft tissue laxity, so that the hip-knee angle is in the range of 174 to 180 degrees, and there is adequate soft tissue stability. The joint line, the joint height should be within 3 millimeters of the native. This is quite a challenge because the other side will have some degree of arthritis, so recreating it would not be that easy. However, maintaining joint line obliquity should be easy with this concept. Now, the warning here is that, or the take-home message is that don't try this technique unless you have mastered the previous two alignment concepts, and then you can mix and match. Otherwise, it can be a recipe for failure and disaster. Thank you, everybody.
Any question from the audience? Thank you very much, Dr. Abhishek.
Thank you.
Thank you, sir. Next speaker is